The focus of my discussion is ventricular ectopies and treatment strategies. I won't be talking to you about too many clinical trials because there are not many. Ventricular ectopies or premature ventricular complexes is a common clinical issue, and it is an easily diagnosed clinical condition, but at times may be very difficult to treat. This slide may be a little too basic for this audience, but for the sake of completion, I would like to describe this. You see a ventricular ectopy, a PVCs, usually a white QRS beat, more than 114 milliseconds. And not preceded by a P wave because there is no atrial depolarization. The QRSs originate from the myocardium in the Purkinje system, and Purkinje system is the distal part of the conduction system, so it is slower and the conduction will be slow. The QRS is therefore wide. And usually this is followed by ventricular repolarization, and the ventricular repolarization is opposite in polarity. So if your QRS is upward, the T wave will be inverted. If the QRS is downward, the T wave will be normal. Sometimes, some patients have a very good retrograde atrial conduction, and some of these PVCs may go up and activate the atrium retrogradely, and you may see a P waves which may be buried in the QRS or even can be seen in the ST segment. And usually a PVC is followed by a pause. However, a PVC sometimes may not be followed by a pause. So how common are premature ventricular beats? It's a very common cause of palpitation. If you do an electrocardiogram on all comer, you will see premature ventricular beat in about 1 to 2% on all EKGs. However, if you do long-term monitoring of the heart rhythm, like in Holter monitor or an event monitor, the prevalence of the premature ventricular beats is much higher, about 40 to 75%. Population-based studies have shown that PVC are also more common in patients with hypertension and older people. And this is because of left ventricular hypertrophy. The bottom line is most people have ventricular ectopies from time to time with variable frequency. Some may have symptoms, others may have no symptoms. So what are the symptoms? First of all, as I say, many people are asymptomatic. But if they have symptoms, the most common symptom is palpitation, and these palpitations can be very upsetting and can significantly disrupt the quality of life in some patients. Other reported symptoms could be fluttering sensation in the chest or chest thumping. Some patients also describe as a cage or a skip beat. Other related symptoms are chest discomfort, fatigue, dizziness, and lightheadedness. A true syncope is uncommon in isolated premature ventricular beats. However, this can occur in patients with underlying non-sustained ventricular tachycardia or sustained ventricular tachycardia, or if the PVC causes significant hypotension, that may cause a true syncope. Our job as a cardiologist is to differentiate PVCs which has more benign prognosis from those which has more sinister underlying arrhythmias. And the first thing we need to do is to check left ventricular systolic dysfunction. Keep in mind, left ventricular systolic dysfunction can cause PVCs. On the other hand, PVCs can cause left ventricular systolic dysfunction as well. In both cases, they are at high risk. Patients with coronary artery disease have a high risk of arrhythmic death if they have premature ventricular beats. Patient with short coupling interval, less than 200 millisecond or fast, non-sustained ventricular tachycardia also have high risk of arrhythmic death. A high burden of PVC, then there is more than 20% of the total QRS complex, puts you also at high risk of arrhythmic death. History of syncope or a family history of sudden cardiac death is also important. So we do have some tools to separate patient with high risk. And the first thing we need to do is to exclude structural heart disease. So we need to separate normal heart from abnormal heart before we embark on treating these premature ventricular beats. Need to take a drug history, patient on stimulants, excessive alcohol intake, tobacco, and patient who are with a high intake of caffeine, that is more than 200 milligrams of caffeine per day, have shown in animal studies to cause or increase the frequency of PVCs, and that will be equal to about 9 or 10 cups per day. Electrolytes abnormalities, family history of sudden cardiac death, and physical examination usually is normal in these patients. However, if they have left ventricular systolic dysfunction or any other structural heart disease, then the physical examination will be abnormal. An electrocardiogram should be done. It helps us to diagnose the origin of premature ventricular beats. The most common cause of benign PVCs is the PVCs originating from the ventricular outflow tract. So if it's from the right ventricular outflow tract, on the EKG, you will have a left bundle branch block type morphology. If it is from the left ventricular outflow tract, the EKG will show right bundle branch block type morphology. Also pay attention to other abnormalities like QT interval, coronary artery disease, left ventricular hypertrophy, and other channelopathies like Brugada syndrome or arrhythmogenic right ventricular dysplasia. It is important to do a Holter monitor on these patients as well as a Venn monitor that help to quantify the number of PVCs. Echocardiogram is important to assess left ventricular systolic function and also, of course, rule out any other structural heart disease. Exercise treadmill testing is a reasonable test to do in a patient with premature ventricular beats. It may increase the frequency of PVC and in some cases may induce non-sustained ventricular tachycardia or even sustained ventricular tachycardia. And of course, it helps us to rule out coronary artery disease. Advanced imaging should be considered in patient if you are suspecting arrhythmogenic right ventricular dysplasia or hypertrophic cardiomyopathy. Coronary angiography should be considered in patients with non-sustained VT or those patients with abnormal stress testing. EPS only when you consider RFA or radio frequency ablation as the treatment for PVCs. This is an EKG to show you how to differentiate the right ventricular outflow tract from the left ventricular outflow tract PVCs. So the outflow tract is at the summit of the heart, that is superior in the chest. So when a PVC comes from the right ventricular outflow tract, the vector will be directed downward to the left leg. That's where your AVF is. So you will have inferior axis, and there will be the EKG on your left. And also, since it's come from the right ventricular outflow tract, it will be inscribed as a left bundle branch block. The PVC from the left ventricular outflow tract will have a right bundle branch block, and the axis will be the same. This is a patient who has what we call a bi-directional ventricular tachycardia, or Catcholaminergic polymorphic ventricular tachycardia. It is not a garden variety VT, but it's a life-threatening arrhythmias, was induced during exercise test. And you may notice that the QRS complexes are rather narrower, and they're alternating. One is upward, the other is downward. That's due to the fact that this kind of arrhythmia uses the left bundle branch block with the left anterior and posterior fascicle and alternating, and you get the QRS upward and downward. I just put this in. Fortunately, this is an uncommon arrhythmia, but for cardiologists who are doing a treadmill, they should pay attention to this kind of arrhythmia. If you see a narrow QRS tachycardia alternating, the exercise need to be stopped immediately, and resuscitation need to be done in these patients. And beta blocker is a very effective therapy for this kind of arrhythmia. So the treatment will be to put them on a beta blocker and then stress them again to determine the effectiveness of the beta blockers. Treatment goal should be focused on two things: patient symptoms and underlying structural heart disease. So if the patient is symptomatic, pharmacological therapy may be needed. And also prevention of the PVC-induced cardiomyopathy. I like to remind you that the PVC-induced cardiomyopathy is different than the tachycardia-induced cardiomyopathy that you may have heard, because in these patients, the heart rate is usually in the normal range, but the PVCs can cause dysynchrony and hypoxia and hypotension, and if you have a high burden of PVC, it can cause cardiomyopathy and left ventricular systolic dysfunction. And if you do have left ventricular systolic dysfunction, that need to be treated accordingly. Treatment strategies. In cardiology, we are blessed by guidelines. So we have established guidelines for almost everything. We have guidelines for atrial fibrillation, we have guidelines for treating sustained ventricular arrhythmia, and we have guidelines for preventing sudden cardiac death, but we do not have any guideline for treating isolated premature ventricular beats. So the treatment has to be personalized, and sometimes you may not need to treat them. So sometimes less may be just enough. So in your asymptomatic patient with a normal heart, just reassurance, and try to tell them to avoid the triggering factors, avoid alcohol, tobacco, excessive intake of caffeine. If you have to treat them, then the beta blocker is the mainstay of therapy, the first line of drug. And if that doesn't work, you can try the non-dihydropyridine calcium channel blocker like verapamil and diltiazem, and some of these right ventricular outflow tract with PVCs or the left ventricular outflow tract PVC, they may respond better to verapamil, the so-called the verapamil sensitive ventricular tachycardia. And sometimes you may need to give a combination of a beta blocker and calcium channel blocker. However, keep in mind that a combination can put the patient at high risk of bradycardia and will need to be monitored closely. Antiarrhythmic therapy, generally speaking, try to avoid that, but if you really have to use it in highly symptomatic patient, then class 3 sotalol, which or potassium channel blocker like sotalol or amiodarone can be used. Again, they will need to be close monitoring. In our practice, when we put patient on sotalol and amiodarone, we only give them 3 to 6 month prescription because we want them to come back. You don't want to put this patient on a high-risk antiarrhythmic and let them go. With no refill, they need to come back and be evaluated. Class 1C drugs, there's propafenone and flecainide can be used in some patients. And sometimes we also use class 1B, the mexiletine, that may help in some patients if they have a normal heart. Class 1A, that is the quinidine, disopyramide, and procainamide should be avoided. You may be familiar to a landmark cardiology trial called the Cardiac Arrhythmia Suppression Trial, which was published in the New England Journal of Medicine in 1989. What they did is they treated patients with coronary artery disease and PVCs with the class 1C drug, that propafenone, flecainide, enconide, morosazine, and what they found that it did work to suppress PVCs, but we were killing the patient faster. They had a pro-arrhythmic effect, and the notion of just suppressing PVCs was disputed in this clinical trial, particularly patients with coronary artery disease and class 1C drug. Catheter ablation is usually a safe and effective treatment, and it can significantly reduce and eliminate premature ventricular beats. If you have a patient who is refractory to drug therapy or have significant side effect, catheter ablation should be considered. And if patient is at risk of cardiomyopathy, consider catheter ablation early. So just to summarize, I would like to conclude to give you some key points. A take-home message that PVCs are common cause of palpitation and also common incidental finding on routine EKG in an outpatient monitoring. Diagnostic evaluation should look for underlying structural heart disease, rule out left ventricular systolic dysfunction, and quantifications of the total burden of PVC by doing a Holter monitor or an event monitors. PVC with no structural heart disease and low burden may be left alone and may not need any pharmacological therapy. However, frequent PVCs, that is more than 20%, carry a significant risk of PVC-induced cardiomyopathy and may require treatment even in asymptomatic patients. And therapy include reassurance, beta blockers, calcium channel blocker, combination, and in some cases, antiarrhythmic. Consider catheter ablation in patients who are refractory or drug intolerant with high burden of premature ventricular beats. And remember, the ablation can be curative in some patients. Thank you for your attention.